to host this evening's episode of my IVF Answers. So today we're talking about preparing for IVF. We're going to talk a little bit about the essential tests that we might think to do as fertility specialists, and other investigations and potential diagnoses. So I'm going to just introduce my guests today. So Dr. Victoria Walker from Institut Marquès in Barcelona, and Dr. Elias Tsakos from Embryoclinic in IVF Greece. Hi, everybody.
Hi,
Nice to
good
see
evening.
you both. Good evening. So let's start by, let's assume I am a prospective IVF patient, and I'm coming to see you for the first time. So perhaps either of you may work a little bit differently to me, but how would you open the conversation, Victoria?
Well, it's always the same. Tell me a little bit about yourself and why you've come to a fertility clinic, and then you start off, just let the patient talk and tell you what they've been through, and then continue with your history. But that's initially just how I would start. Just ask them what they've been through to get to your door.
And what tests would you all like to have? What tests would you both like to have had done, or what tests would you organise or request before thinking about moving on to IVF?
Well, first of all, you've got to sort of work out if IVF is the right thing for them. But assuming that IVF is what you think is the right thing for them, and they agree, then you can start with all the tests. So there are lots of blood tests, and there are tests of the ultrasound and the sperm test, and we can go through all of those individually, of course. Those are the main ones, but there are others.
So just like me, you would request a sort of some blood tests, a scan, and probably a semen analysis if you're a couple. Fine. So so then what would you then suggest to the patient? So these are the essential tests to identify potentially what the problem is, and help to guide you in terms of your treatment protocol. And what sort of scans would you request? What would you suggest is done? What are you looking for?
Just me? Or I don't know if you want Dr. Tsakos to answer. I don't know.
I don't really mind. Dr. Tsakos, what would you be requesting on your ultrasound scan? What are you looking for?
Sure. Well, thank you so much again for inviting me and for hosting this event, Shabana, and thank you, Victoria, for taking the first questions. I mean, I thought that you were going to complete before my turn came. So anyway, thank you for giving me the floor. I mean, my approach is a little bit different. I mean, before I actually get to personally see the patients, I mean, I'm the medical director of a decent size unit in Greece. But well before I see the patient, we have a slightly different system. So we send some questionnaires to the patients in order to get as much information as we can before they walk into the door, either physically or online. And once they've filled in those questionnaires, this is saving us about 1 hour of questioning. And following that, and also is giving us the opportunity to understand at what stage in the journey they are. So we rely very much on that. And of course, we'd like to request some tests that have been done until now, because more often than not, our patients are not fresh. So, they're not just starting the journey, they're just somewhere along the path of their journeys. So we like to review everything before we start interviewing them, if you like. So that's how we work. And then, of course, depending, and we have a very specific section requesting the patients what are they looking for in terms of care. Are they looking for a second opinion? Are they looking for exploring the options? Are they interested in whatever IVF, IUI, surrogacy, egg donation, sperm donation? So we like to get an idea, get a feel of the patients before we even meet them. And then, of course, once we've met them, then generally we go through the tests. And again, we do this at different levels. So they start with the midwife. I mean, an initial appointment at Embryoclinic may last as long as 2 hours. So they start off with a midwife, fertility midwife, very experienced fertility midwife. So they go through everything. They highlight some possible questions and all that. And then they see one of our fertility doctors. And then eventually, when I get to see personally my patients, and I do personally see all the first appointments in order to understand what's going on, more or less we have formed an idea of what needs to be done and which way forward we can go. So we try to complete the puzzle usually, as opposed to drawing the painting from the beginning.
Okay, so that's very comprehensive, a little bit different from our approach. Yeah. So then, was there anything else that you wanted to add to that, Victoria?
No, I mean, we're not actually very dissimilar to that. I was thinking just generally, what do I do when I see the patient? But as a clinic, it's pretty similar. The Institut Marquès requests quite a lot of information from the patients, which we go through before we see them. They don't see a midwife or even a nurse beforehand, but somebody has been through their notes and put it all on the system so that the medics can see them, see the results. And then we individually see our patients online or in person, of course. And when we see them, then we become responsible for that person. And I'm sure we do have the director watching over us, but not immediately. And so we see our own patients and follow them all the way through the whole process. And indeed, of course, ask them what they're here for. And often you think you know what they're there for, but it can sometimes surprise you with what they actually say. But then once we've seen what they've done, we can often add extra things, but the basics are often very similar.
And
the bloods, the ultrasound.
And with respect to testing, are there any mandatory tests that you really want to see at that initial investigation? Is there anything that you would like the patient to have brought with them or present with or anything before you can even consider starting IVF?
Well, if it's just the first time I'm speaking to them and they haven't got any tests, well, then I can request them. But before I'm going to give anyone any medication, and we're just at the moment, according to the title of today's session, just talking really about IVF, then I personally would want to see an AMH test, and if possible, an ovarian, scan, and to check the number of antral follicles. Those are the real things that I'm wanting to look at. There are plenty of other details that I want to know as well, but those are the really for me, the really fundamental ones.
And would you say the same, Elias? Would you say there's a similar sort of?
Yeah, absolutely, yes. I mean, definitely these are very important factors, but also equally important, in my opinion, is the scanning. I mean, there's different levels of scanning. Is it standard scanning, 2D, 3D, 4D? Is it high resolution? What are we looking for? Are we looking for just AFCs, follicle counts? Are we looking for endometrial factors? Are we looking for endometriosis, myomas, and all that? So I have to admit that since most of the patients that come to us are way far into their journeys, so most of our patients come from abroad. They've had lots of history, lots of failed attempts, failed pregnancies, failed implantations, and so forth. So we try to go a little bit of the extra mile. So, for example, I put a lot of effort and value in 3D scanning, in high resolution scanning. We all know only too well that a standard sort of scan doesn't reveal very much. And that, of course, depends. I mean, I have seen some incredibly low quality images from scanning performed by perhaps not so specialized doctors and technicians for that matter. So we pay a lot of attention in examining. I mean, to our mind, examining the patient is providing them and us, of course, with the high resolution scan result. And I think this is critical. We may identify, apart from the follicle count, also the quality of the myometrium, the quality of the endometrium, which is not just thickness. There's other parameters as well. We look very carefully for endometriosis, remembering that endometriosis may affect as many as 1 in 2 of our fertility patients.
Mm-hmm.
We look very carefully for hydrosalpinges, because we know only too well that this is not part of standard investigation, and we also know that they can easily be missed on a very standard ultrasound scan assessment and so forth. We believe a lot, and we perform a lot of hyphosis, a lot of specialized scanning with foam in order to identify the quality of the tubes as well, trying to understand if there's anything else that we're missing out. I mean, this is, I would say, this is the main focus. The main focus of our initial and assessment overall is to identify what's been missed out.
Yeah, right. Okay. So you do tubal testing on all of your initial consultations, or does it like case by case?
I wouldn't say all, but yeah, we do a lot of that. Yeah.
Mm-hmm, mm-hmm, mm-hmm. Okay. Okay.
Do you do hysteroscopies, or do you mainly focus on the foam tests and things like that?
Well, it depends.
I mean, they're looking at different things, but do you do also hysteroscopies?
Answer is yes. Clear answer is yes. I'm a strong believer of the value of hysteroscopy, and I believe it should be part of the essential, obligatory in a way, assessment. I'm aware of the evidence, which is not huge, but this is simply because of surgeons not publishing as much as IVF doctors do, or scientists from the lab for the matter. But I mean, we have some literature as well produced by our department. But I do believe in hysteroscopy. I think the value of hysteroscopy is increasingly important as women are advanced age, and they tend to be, most of them, of advanced reproductive age. Older than 35, older than 40, or older than 45. And the value of hysteroscopy there is quite significant.
And what are you looking for in a hysteroscopy? So what would alarm you, or what is it that you're looking for in hysteroscopy?
Sure. We'll look for everything. I mean, for me, hysteroscopy is like a mock trial of transfer to start with. Mm-hmm. I hate difficult transfers because I know only too well that that's associated with a bad outcome. And for me, optimizing a transfer through a hysteroscopy could be the one and only reason that would make it indicated. Mm-hmm. Women who haven't delivered vaginally before, in their late 40s, for example, I mean, the chance of having some sort of stenosis or adhesions in the cervix, or some sort of difficult cervix to negotiate, are more common than not. So factor number one. Factor number two, there's a lot of pathology that is easily missed even with high resolution scanning, whether that's focal hyperplasias, small polyps, hyperplasias. Many women have myoma, so I like to have some sampling of the endometrium for those women for standard histopathology, signs of endometritis, signs of adhesions. I mean, diaphragms, previous surgeries. For me, a hysteroscopy is a very important tool. It's become very, very low minimal access. I would say it's not minimal access surgery, it's a minimal access solution. And I think overall, the value is very, very important. And of course, we always couple that with biopsies, assessing various aspects of the endometrium, biopsies, endometritis, microbioma is becoming more and more in vogue recently. So we like to know a lot about the uterus, and I think uterus, we have been focusing. I mean, I don't know Victoria's background. I would be very interested to hear that. But my assessment of how IVF has moved or has been happening in the last 30 years is that most of the focus has been placed on the lab, which is wonderful. Of course, it is very important, but I think we need to shed some light on the clinical gynecological aspect as well, on the anatomy, on the skills of the surgeons, of the IVF specialists and all that. But of course, we need evidence for that.
Victoria, do you have anything to add about the role of hysteroscopy in uterine cavity assessments and so on?
No, we have a very low threshold for requesting hysteroscopies as well, because our patients are, like Dr. Tsakos is, they're from all over the world. It's sometimes easy to get them done and sometimes not so easy to get them done. So if they come from the UK, it's not so easy. If they come from Australia, it is easier. France, it's easy. It depends on the country. So we have a low threshold for testing, and we do them ourselves quite easily as well, and always add in the biopsies too. So we do a little bit of 3D ultrasound. Some of my colleagues do that. We're starting to use the foam tests for the tubes a bit, but not very much.
Yeah.
But yeah, the hysteroscopy is the main thing we still do to check the uterus. But it's funny because I was talking to somebody not very long ago, and he was saying the hysteroscopy is very outdated. Why does anybody still do it? You can see everything you need to see on scans. And I was thinking, I didn't think so. I think we definitely find things that you can't see on a scan.
Yeah, I would definitely disagree with that as well. So okay, so then so we sort of covered some tests, some scans, and then some diagnoses. So I might move on to some of the questions now. So one patient has asked a question about her low ovarian reserve. So she's very concerned about her low ovarian reserve. She says she has an AMH of 0.17. I don't know what the unit of measurement there is, but I would assume that it's low, whichever unit of measurement you're using. So she's asking, do I have a realistic chance of success with IVF? Elias, do you want to answer that question first?
Provided you're having periods, the answer is yes, absolutely you do. 41 is a reasonable age to expect good quality eggs. It may take more than one cycles. It may take many natural cycles. It may take a few months, many months, a year maybe, or longer. But if you're having regular periods, I think, there's a chance there. There's a chance that you will have a good quality egg that will produce a good quality embryo and you will get pregnant. So, my team and I, we have published a lot on AMH. We were amongst the very first in the world to publish in 2011. Well before, that was the publication. We started our research in 2007, well before AMH became a standard of practice. And if I know one thing, I know this, that AMH can be deceptive sometimes. So I tend to trust the scanning as well and combine scanning outcomes with, AMH result is not written on stone. So if you're having regular periods, I would just, press on, perhaps have some mild stimulation, aiming to produce a couple of eggs. If despite the mild stimulation, you only produce one egg, I would just move on with natural cycles, find a friendly clinic with flexible programs, being able to do pickups on Saturdays, Sundays, bank holidays, Christmas days, and Easter holidays and so forth. And I'm sure you will find a good egg. I'm pretty sure about that.
Victoria, would you agree with that?
Yes, I would agree. I would say, though, that you have to prepare yourself for every eventuality, and it could take. Dr. Tsakos mentioned maybe up to a year, multiple cycles, and prepare yourself for. we in our clinic would do PGT testing of the embryos to see what the quality is. And we know that the quality at 41 is often not great. So it's a question of keeping going and things like that. So I would say yes, we can definitely try, and we can try multiple times and try multiple collections. But if you're open to it, an egg donor, because of your age, would probably give you a higher chance of success. Anna wasn't asking that in her question,
No.
but these are things to discuss in that first consultation with regard to age and chances of success.
Okay, so it's two slightly different approaches, but more or less everybody is saying that yes, you can, but I think with the caveat that the chances are on the lower side, or you have to look to committing time and certainly in our case money to go that length. Fine. So then there's another question here from Erica, who said, are there any holistic treatment that you could add to your fertility journey? So I suppose that's going back a little bit to, are there any recommendations for preparation in terms of starting IVF treatment? So both of you may have different views on that. What are your thoughts toward somebody saying, oh, so how would you recommend that I prepare myself for my fertility treatment if I was thinking about having fertility treatment in the next 3 months, let's say?
Yeah. Should I take that one?
Yeah, sure.
Yeah, if somebody's 3 months is quite a short time frame for thinking you're going to start. You sometimes need to think about it maybe a little bit ahead of that, to try and get yourself into the best possible health. Ideal weight, eating healthily. Very few people now smoke, but stop smoking. Trying to make sure you're as healthy as you can possibly be, and your partner is also. Both of those factors are important. And partners are important, very important too. And yes, you can look at supplements. There are quite a lot of supplements, and nutritionists are very keen to give supplements to try and help with egg quality. I can't say I'm a specialist of knowing exactly what will help, but just subjectively, I've seen with CoQ10, the numbers of AMH can really increase surprisingly quickly and high. And I was amazed by that with some patients of mine. So, but the nutritionists, the people who really specialize in that, can give very detailed advice as to how to improve a person's nutrition, to make sure that their egg quality is as good as it can be, and the sperm quality is as good as it can be if they're in a heterosexual relationship. And yeah, it can make a difference.
Mm-hmm. Elias, would you say the same? Would you agree with that?
Yeah, absolutely, I would 100%. If I may add, one thing is that I'm a great believer in individualization of all the management. So I prefer to invest on testing more than treatment, so that I know what I'm treating for. So just exactly how Victoria said, I think collaboration with nutritionists is vital. And most importantly, also, our patients, they need to understand that IVF is like a performance. It's like a game, like a match, like a test, like an exam, like going on stage in theater. They need to prepare, and then perform. So I think anything we can do to optimize any factors we can get our hands on would give this edge for the success, not only the success of IVF, but also a successful pregnancy and a successful childbirth. So yes, by all means. I think anything we can do to support the whole system. I mean, a woman is not just eggs and uterus, and a man is not just sperm. I think we need to be very clear about this. Anything we can do to support the environment surrounding those important genetic production areas, I think would make a difference.
So if I ask you a question about this this theory of holistic fertility care, what sort of aspects would you say are important? So we talked about diet and exercise, and stopping smoking. We talked about Q10. Are there any other adjuvant, or let's say alternative therapies or supports or adjuncts that you would recommend in the treatment or suggest? So this patient in particular, she's suggested reflexology, for example.
Is that for me?
Well,
yeah,
go ahead.
Go ahead.
If you want to answer that question first, yeah, that's fine.
Go ahead, Victoria.
Okay, Victoria.
Okay. All right. No, yes, reflexologists. Again, is not an area that I find I know that much about, but the reflexologists I've worked with are very, very clear and very good at explaining to their patients how they're helping, and it does seem to help them. And similarly with acupuncture, I don't know that much about acupuncture and exactly how it works to help people, but it does seem to help. So these are two things that I would add in, both of them, if people want them. I mean, if somebody is a needle phobic, you're not going to say try acupuncture, but if they are open to it and it's not too expensive, and I don't think it can do them any harm, and it may well help them. And psychologically can be really helpful. They're really good at supporting patients through their treatments as well.
Mm-hmm. Elias, would you? Is there anything else that you want to add to that, or any other adjuvant sort of alternative therapies that you would potentially advise or not advise, in fact?
Sure. Acupuncture, I agree 100%. I think there's a lot of scientific evidence at the moment supporting its value. And there's a lot of mechanisms that can explain that. So it didn't come as a surprise that the evidence is there. But anything we can do to show our patients that we don't treat them like anybody else, I think this is very important. And if we want to individualize, I think it's important to know some essential information about them first. For example, vitamin D levels. I mean, we all know how important it is. We all know that it's behaving like a hormone rather than a vitamin, and so forth. It regulates a lot of mechanisms in our bodies and all that. So anything, especially in the winter, it becomes even more significant. So simple stuff. I mean, CoQ10 we can measure in the blood, so presumably we can titrate the amount of vitamins we supply with, and so forth. So there's always something we can do extra, as long as we take time to analyze what's been done, take time to justify perhaps what we're doing, and take time to confess what we don't know, because we don't really know everything. So I think this may create a net of trust around our patients, and then it would make the whole experience, as Victoria said, the value, the level of experience is very valuable, because this is what's going to give patients the motivation either to move on in case of failure, or not to give up, or even in pregnancy afterwards. So, if the whole procedure has been a positive experience, it has been proven that it affects the course of pregnancy and childbirth.
All right. So I've got another question here from one of the audience. So she asks, has anyone actually been able to raise, I think she means it, like increase their AMH? Is it possible to increase your AMH? So she says, I've been taking supplements for 90 days. So she's been taking supplements for 3 months, and I've tested it again. And in fact, if anything, it's slightly lower than it was before she started the supplements.
Sure.
So I know the answer. I know my answer to that question. But what would you both say about the AMH and whether or not you can increase your AMH?
Sure. Can I take this? Because I have a very strong view. As I said, I have huge interest in AMH. Huge interest. I mean, our papers are cited in the European Society of Human Reproduction in the ovulation induction protocols and guidelines and all that. And I'm also a member of various groups, and I'm very tempted every day. I don't do it. I wish I had the courage to do it and perhaps save some people unnecessary stress, but I don't do it. So let me be clear about some facts, and please, Victoria, it's amazing that you're here. Please challenge me on that. I think you're the best person to do that.
Oh,
I mean, first
I'm going to listen and learn.
Yeah, stop measuring AMH. Please don't waste your money. Go on a holiday. Don't measure AMH every month. The variability. I mean, even in standardized labs, the confidence in how can I say it simply? I mean, the chance of the plus or minus 15-20% is part of the game. It doesn't mean you have 0.7 and you do whatever you do and you eat whatever you eat and then it becomes 0.29. It doesn't mean anything. So stop measuring AMH every month. It's not that important.
Yeah,
AMH is an indicator. It's like IQ for people. I mean, stop measuring IQ. It doesn't predict anything. Measure the output. Sorry, I know you want me to stop very soon, but give me 1 second. Stop measuring AMHs. Please save yourselves money, trouble, stress unnecessary. 2, the most important indicator of the performance of the ovary is the ability to produce eggs. It's not the ability to have a higher AMH or a higher HC. So the best way to measure how the performance and the output and the reserve of your ovaries is how many eggs and what quality they are. So these are my 2 messages, and I'll allow Victoria to comment if you could.
No, I think it's true. I think, but the other element of the AMH, I agree, you mustn't check every month. There's absolutely no point doing that. But it does, if we're remaining on the, the context of IVF, it does guide you regarding the doses of medication that you might want to try for them with the patients and things like that. So it's got that use as well. But it's true that it can fluctuate and it can increase. It can sometimes increase. As I said, with that patient who took CoQ10, it suddenly went for her from about 2.5, and this is our units, nanograms per mil, up to about 3.9. But this was from 1 year to the next. So again, different labs, don't know how much, and things like that. But she was delighted. But was it the CoQ10 or the different lab or whatever?
Yeah, well, this lady's saying that it's she's been taking supplements, and in fact, if anything, it's gone down. So it could have been
not to worry.
So the answer is to her question is not to worry too much about the actual AMH value itself. We don't seem to have any other questions, but so if you've got your you have your patient, you have your diagnosis, and your patient's decided that after 3 months they're going to start their treatment, is there anything else that you would want to offer her to help her, to support her during her IVF process? Is there anything else that you might want to support her with? Well, maybe like in a holistic way. Victoria?
Well, you might have a psychologist. If you've got psychologists in your clinics, you can offer support with a psychologist. With an international clinic, that can be a bit hard to be able to offer psychological support in the language of the person, because I always think you lose through translation. But they don't, if you don't have a psychologist as such, then, the medical team, because we have a medic and a kind of nurse specialist and
Signal's not very good at her end. Elias, what would you suggest? Do you have psychologists in your clinic as well?
Yes, we do, and we have dietitians, we have acupuncture specialists. Occasionally, we do some fertility massage as well, which we found that it may alleviate a lot of stress.
So you have a massage, sort of a masseuse in the clinic, do you?
Not on site, but yes, we have collaboration with external associates and so forth. So anything we can do to relieve stress, anything we can do to help them focus on the treatment. I think one of the main issues our patients have is that we all do. We live very complicated lives, and they try to juggle everything together with an IVF cycle. So if we manage to help them focus a little bit on the IVF, take a little of time out, 2 weeks, 3 weeks, 4 weeks, and focus on the IVF, have a positive mindset, look after the body, the mind, the soul, then it helps a lot. I mean, that's my belief. And of course, in order to do that, I mean, that for many patients is a luxury. We need to exclude some very serious and solid medical factors. For example, I mean, even now, patients undergo IVF without having had, for example, DNA testing, karyotype testing, without having had cystic fibrosis testing, without having had very, very standard thyroid checking, vitamin checking, glucose and HbA1c checking and all that. So I think once we've excluded important medical factors that may be associated with not only failed IVF and implantation, but also complicated pregnancies, then of course we can look into the luxuries of relieving stress and of course making the experience much more bearable.
Also, it's very interesting. We've lost Victoria in the conversation. She may have had an internet problem, but it's very interesting that you say that, because that's quite different from our approach, where we tend not to necessarily investigate patients to that level before an IVF cycle, and only really those investigations only really start to come into play if you're sort of on a second cycle, or like you say, if you've got recurrent implantation failure or something like that. So that's quite different from the approach.
Can I ask, are you based in the UK or
based in London?
And I mean, as you probably know, I was trained in the UK. I was trained in England for 10 years, so I'm very familiar.
You're back.
Yeah, thank you. I'm very familiar with the UK system, and also I hold a current license to practice as a gynecologist in the UK, which I do. So, if you allow me, there's one thing trying to do IVF, and there's another thing trying to make sure that at least, you justify some essential tests. And, no matter how you look at it, I mean, for example, a karyotype test a few years ago, perhaps 10 years ago, would cost a few £1,000s. I mean, now is a few £100s. So in the whole context of cost, stress, I mean, how many times, for example, I have been faced with this many times when I was in the UK after 2 or 3 failed attempts, when we discovered that there was a DNA problem in the couple. And I got this question: doctor, why didn't we test for this earlier? Why did I have to go through 3 failed IVF, 1 ectopic and 1 miscarriage to find out that I have a DNA problem? So that was a little bit of a difficult situation.
Well, that's right. So we're working in this country in particular, where government funding is restricted, and tests in private healthcare can be very expensive. And if you're talking specifically about chromosome testing, you could argue that if you're doing more and more PGTA, then would there be any role in doing karyotyping prior to doing PGTA? Because whether or not that's going to then influence the outcome. But
well, if you allow me to comment on that, I think it's not. I don't think it's a fair comparison, simply because one is a non-invasive test with no risk whatsoever to the embryo, and the other is an invasive test which is associated. I mean, PGTA is not a solution to everything, in my opinion, and using universally PGTA is never going to solve most of our problems. Yes, it is an important test. Yes, it has important value, especially after the age of perhaps 35, 37. But, it's like comparing doing amniocentesis with prenatal testing with non-invasive prenatal testing. So
I don't think I would necessarily agree with you. I wasn't saying that we do PGTA on everybody. I'm just saying if you're planning on doing PGTA, then you might argue that there wouldn't be any role in having to do a karyotype at that point. And I think outside of the context of recurrent miscarriage, or certainly like recurrent implantation failure, I'm not sure doing a karyotype on everybody is necessarily is going to be beneficial.
Well, let me. I love this discussion. It's heating up. But karyotype testing is £500. PGTA with IVF is £10,000, which is more valuable and cost effective. PGTA is telling us about this embryo, this one embryo or two embryos. Karyotype testing is telling us about.
Now we've lost Elias, so we've between us, we've difficult for us all, the three of us, to be on the screen at the same time at the moment. I don't know.
I'm sorry. Anyway. Can you hear me? Am I here?
I can hear you. We haven't had any other questions. Yes, you're here. Can you hear me? Can you hear me?
Oh yeah, no, I can hear you. I can hear you. Sorry, I come and go.
We don't have any other questions at the moment, so we might just wrap up. Actually, I just wonder. So we've more or less summarised everything. We've talked about essential tests. We've talked about the value of detailed ultrasound scanning, and we've talked a little bit about the sort of diagnosis and the wraparound sort of holistic care to support. Is there anything else that you want to add, Victoria? Unfortunately, we've lost Elias, but.
I don't know. I mean, I was thinking about there's sort of a set of things for which there is consensus. So those are the blood tests and the ultrasounds, as you've just mentioned. But there are things like karyotypes. Should they be done? Laparoscopy.
We were just having that conversation before you went off last.
Sorry, I missed that.
Yeah. So just out of interest, what is your take on that about sort of blanket karyotype testing?
No, I don't know what you said. No, we do a lot of karyotypes. We do a lot of karyotypes, but we don't do any laparoscopies ever. I remember seeing Prof. Winston speak once, and he was adamant that everybody needed laparoscopy first. And maybe when he was doing IVF, 20, 30 years ago, that was something really, really important. But nowadays, you need to have a laparoscopy for somebody with, endometriosis and is very symptomatic, but not necessarily to help them with their IVF and things like that. So no, those are the things. What was my colleagues?
We're having a bit of a heated discussion about whether or not everybody should have a karyotype. So my argument
was he saying you do need it?
Well, so we were talking about PGTA, and he said, well, it's probably better to do a karyotype than to just sort of do PGTA, because that's far more invasive. But I think from my point of view, it doesn't change what you're going to do necessarily. So, but also there's a cost implication to do a karyotype in the UK, and it's quite difficult to get that on the NHS too. Without good indication,
I would say on the NHS. I think
possible on the NHS, yeah. Unless, like I said, it's in the context of recurrent miscarriage or something like that. Okay, I think we were slightly digressing. So I don't think we've got any other questions, and unfortunately we've lost Elias. But thank you to him on from us, and thank you, Victoria. I'm sure we'll catch up soon. Thank you, everybody.
Pleasure.
Good night.
Enjoy your evening. Thank you for the questions, and enjoy your evening.
Thank you.
Bye. Bye-bye.